We would like to present our double figure of 8 sternoclavicular joint reconstruction using an ipsilateral Palmaris longus autograft augmented with a fiber tape internal brace. This reconstruction was named the crisscross technique. We do not have any disclosures. We present the case of a traumatic left posterior sternoclavicular joint dislocation in a 40-year-old woman who was involved in a high-energy road traffic accident. The 2D CT scan, coronal view, and 3D reconstruction demonstrate the posterior dislocation and proximity of the vascular structures. We first attempted a closed reduction which failed, necessitating an open reduction and reconstructive surgery. This technique requires to check preoperatively for the presence on the ipsilateral side of the palmaris longus tendon with active opposition of the thumb against the fifth finger. The patient is placed in supine position with draping of the entire thorax and the ipsilateral arm. Access to the thorax is desirable in case of major vessel injury during the surgery, necessitating an emergency thoracotomy. First, the palmaris longus graft is harvested. A transverse incision of 1.5 centimeters is made at the level of the wrist flexion crease. After subcutaneous dissection, the palmaris longus tendon is identified, exposed, and prepared. A traction suture is placed to allow for proximal tendon dissection, followed by palmaris longus tenotomy distally to the traction suture. The graft is then introduced into a closed tendon stripper. The tendon stripper is stopped approximately 8 centimeters proximally to the previous incision, and another small transverse incision is realized. The tendon is externalized from the second incision and then extracted using the traction suture or a non-sharp clamp, with the closed tendon stripper directed to the flexor pronator mass. The graft is then secured with a reinforced, non-absorbable suture at both ends using a Krakow suture technique. We then proceed to the exposure of the sternoclavicular joint. An 8 centimeter skin incision is made in front of the sternoclavicular joint. After subcutaneous dissection, the sternoclavicular joint capsule is opened. A traction clamp is placed on the clavicle, allowing easier subperiostal preparation of the medial edge of the clavicle and manubrium. The sternoclavicular disc is then removed from the joint. The medial clavicle and manubrium are prepared subperiostally using a respiratory, taking care when dissecting posteriorly to the joint regarding the underlying vessels. 2 anteroposterior holes are drilled into the inferior and superior part of the manubrium. An oblique 4.5 mm antero-superior hole is drilled directly to the posterior inferior part of the clavicle, followed by a second oblique antero-inferior hole directed to the posterior superior part of the clavicule. Shuttle relays are placed into each hole with a Hewson suture passer. The palmaris longus autograft and a fiber tape are passed into the clavicular antero-inferior hole from anterior to posterior. The graft and the fiber tape are then passed into the manubrial inferior hole from posterior to anterior. The graft and the fiber tape are then passed into the clavicular antero-superior oblique hole from anterior to posterior. Care must be taken to tension the graft and the fiber tape at each hole to ensure final stability of the reconstruction. Finally, the graft and the fiber tape are passed into the manubrial superior hole from posterior to anterior. The sternoclavicular joint is reduced, then the graft and the fiber tape are tensioned to ensure good final stability. The fiber tape is secured first. After tensioning, the graft is then secured with knots between both ends. The graft knots are protected with multiple non-absorbable fiber wire sutures between both ends and into the previous knots as additional offloading and protective sutures. After irrigation and disinfection, the sternoclavicular joint capsule and fascia over the joint and medial clavicule are closed to ensure good covering and additional stability of the construct. Skin is closed with a running intradermal locked suture. 6 months follow-up evaluation demonstrated good stability during protraction and retraction movements. The patient was satisfied, demonstrating good outcomes following this surgery.